Hello and welcome to our first live event tonight. I am Caroline, your host as always, and I'm happy to be back here. And we will definitely have another interesting online patient meeting, and we have another special guest with us tonight. And first, just let me remind everyone that all of our events, Stronger Together events, of course, are brought to you so that you can simply find out a bit more on any aspect related to IVF treatments. And of course, since right now it's not possible for most of you to continue with your treatment, we are simply here to support you and provide you with as much details as we can. And that is why we are inviting our top experts every single day to make it a bit hopefully we are able to help you a bit. Okay. And of course, all those events have been brought to you thanks to our ambassadors and partners. So I will not name everyone. As you can see, there are plenty of those ambassadors and partners, but I'd like to thank them for their support and joining our initiative as well. And tonight we have another interesting topic to discuss, and the topic is: why are we recommending single embryo transfer in our IVF program? So definitely a question some of you have already been asking. And well, tonight we have another guest. As I mentioned, it's Dr. Cinzia Caligara, and she's the gynecologist at IVI Clinic, which is located in Seville in Spain. And of course, Dr. Caligara will be happy to answer all of your questions as well. So as always, we will start with most common questions, and right after this, it will be time for your questions. So all you need to do is type those in the chat section. Please let us know that you can hear me. And Dr. Caligara, hi, how are you feeling today?
Hi, thank you for inviting me, and I'm very happy to be with you. And nice to be here.
Excellent. Perfect. Thank you so much for clarifying that. Sorry, for confirming that you can hear us both. And well, we will start off with some of the questions. Okay, so Dr. Caligara, are you ready to begin with the questions?
Yes.
Excellent. So the first question that we have is, so what is elective single embryo transfer?
Elective single embryo transfer is the transfer of only one embryo when we can choose that embryo from a group of embryos. This is different when we have only one embryo. This is not elective single embryo transfer.
Perfect. Thank you so much for answering the very first question. And let's go to the next one. Why should we prefer single embryo transfer?
Well, basically to avoid twin pregnancies. In nowadays, in most of the clinics or in our clinic, we have very good pregnancy rates with single embryo transfer. Doing transferring two embryos will add around 5% chance more of pregnancy, with around a 70% risk of twin pregnancy. And we know that twin pregnancy have higher risk both for the babies and for the moms. Mainly the risk of premature labor and birth, with all the pathology associated, a higher risk of congenital malformations, and for the mom, a higher risk of hypertension, premature labor, diabetes, polydramios. And the point is, even if the risks of a twin pregnancy are assumable, the ultimate goal is to have a healthy baby and a healthy mom, and this is easily achieved with a single embryo transfer. And we do not lose a significant amount of chances of pregnancy. So that's why we recommend and we prefer transferring one embryo at a time. If we see the cumulative pregnancy rate, so the total newborns after a cycle, we have more babies if we transfer one and then another one than if we transfer two at a time.
Perfect. Thank you so much for clarifying that. This is a question we definitely often receive, so thank you for explaining. And now let's go to the next question. What are the risks of multiple pregnancies?
So the main is the risk of to be born earlier. And even if this risk of premature birth is present even in singleton pregnancy, this is like 1 out of 10 of the singleton pregnancies to be born before week 37. In twin pregnancies, the risk is 6 out of 10. And in triplets is 9 out of 10. And in higher order is 100%. So the mean age of delivery of twins is 36 weeks. If the baby is delivered before 37, there are like stages of prematurity. It depends on the neonatology unit care of the hospital where we are going to deliver. But usually the survival is around 28 weeks with a high rate of complications, and above 32 is there is a higher survival, and above 36 is a quite high survival rate. And the point is, if patients want to have a twin pregnancy, what I would suggest is to ask not only her obstetrician about the risk of twin pregnancy, but also find out with her pediatrician or the neonatologist, which are the resources at the local hospital, and what is the advice that the pediatrician will give her. Probably the obstetrician will be okay to have a twin pregnancy, but for the neonatologist, not. It will not be the same opinion, and the pediatrician, neonatologist will push for a singleton pregnancy.
All right, thank you so much once again for explaining this question. Next one is right here. So does transferring two embryos increase your chances?
Nowadays, with the blastocyst stage embryo transfer, in absolute numbers, it increases about 5%. And why is not the double or higher than that? Probably because there is a lot of immunological dialogue between the endometrium and the embryos, that with two embryos, it increases the chance that one is compatible and the other not. Other studies have interestingly demonstrated that if we transfer one good quality embryo alone, we have a higher chance of pregnancy than if we transfer one good embryo with one accompanying embryo, not so good quality. So yes, it has usually a 5% chance, but a higher percentage of pregnancy, but with a very higher risk of twin. And if we transfer one embryo and if it fails another embryo, we end up with more newborns than if we transfer two embryos at the same time.
Perfect. Thank you so much once again for answering this question. We will go to our final question when it comes to those most common ones, and then it will be time for your questions. So as always, please type those in so that Dr. Caligara can simply help you out a bit as well. Next question in such case is, can I have multiple pregnancies after a single embryo transfer?
Yes, it is possible to have twins after a single embryo transfer because of the phenomenon of twinning of the zygote, and those will be identical twins. And depending on how early is the splitting, they can have two placenta and two amniotic sacs, or just share the placenta with two amniotic sacs, or share the placenta and share the amniotic sacs, or be conjoined twins. And the twins that share a placenta have a higher risk than the twins that have each a placenta and an amniotic sac, and so on. The twins that share the amniotic sacs have higher risk. And that's another, and this can happen either with one embryo transfer. The incidence is low, it's about 1 every 80 pregnancies. That's about 1.5%. But it can happen also if we transfer two embryo and one of them can have this phenomenon of twinning, so we end up with a triple pregnancy.
Perfect. Thank you so much once again for answering that question. And now, well, it will be time for your questions. So I will wait for the first question to show. Oh, okay, perfect. Thank you. I can see them. Today, we just need to do it a bit differently. Okay, I am not able to show the question on the screen as we are having a bit of a technical issue, which I cannot fix right now. Our team, our platforms team are working on that, but it looks like it's not possible to fix this so fast. Therefore, I will be reading out the questions, and of course, Dr. Caligara can answer. So you can see, of course, the questions in the chat as well. Okay?
Okay.
Perfect. So the first question is, does this information also apply to transfer of 2 day 3 embryos, or is this information only applicable to transferring 2 day 5 embryos?
Well, mainly to day 5 embryos, because we know that around half of the day 3 embryos doesn't evolve to blastocyst stage. So we are speaking about blastocyst transfer.
Okay, thank you so much for your question as well as your answer to that. Next question is, so when does the division to twins take place?
It is thought that is very early after implantation, and it depends on the moment. It will the embryo will divide completely, and this will lead to monozygotic, bichorionic, biamniotic twinnings. So identical twins from one embryo, one egg and one sperm, with 2 placenta and 2 amniotic sacs, or, which is more common, only 1 placenta and 2 amniotic sacs, or 1 placenta and one amniotic sacs, or the conjoined twins.
All right, perfect. Thank you so much once again for answering this question. The next question is here as well. So what's the most dangerous part of the freezing an embryo?
Well, I'm not an embryologist, but I'm aware that with the new method of vitrification, it's a very safe procedure, because the problem that occurred in slow freezing, that was the formation of eyes, needles is not present. The risk of not surviving after vitrification is less than 5%. But I'm not an embryologist, so I don't know if this answers the questions.
All right, thank you still, of course, for answering the question. As you can see, Amy has already said thank you for that, so all is okay. Okay, next question you can see as well. Is it better to use injected progesterone?
Well, we now at IVI have a protocol that has been developed after an excessive research. That if the absorption of vaginal progesterone doesn't reach a level of progesterone above 8 picogram per milliliters in blood, we supplement with subcutaneous progesterone. And these supply the lack of progesterone. If the level of progesterone is above that level, is not necessary to use injected progesterone unless the patient wants to, because of comfort of not using vaginal pessaries. In Spain, we do not have oral progesterone commercialized. And now we have the subcutaneous progesterone, and we do not have a commercial form of intramuscular progesterone. Is a pharmaceutical form that is made specially for the patient, but is not commercially available.
All right, understood, of course, perfectly. Thank you so much. In the meantime, it looks like our technical issue has been fixed. We can now show the questions right here. Next question is ready as well. Just a second, it's right here. So, can I fly during my first trimester of IVF? IVF, yes, when it comes to pregnancy.
Yes, there is no contraindication to fly.
All right,
no
excellent. Thank you for clarifying that. Next question is here. So my TSH is 3.24. Is that a normal level?
Okay, it's a normal level, but when we are looking for a pregnancy, actively looking for a pregnancy, we do prefer to have the levels of TSH below 2.5. So we will, if you are a patient of mine, I will give you some medication to lower the level of TSH below that level, below 2.5. Even if 3.24 is a normal level, and if you are not looking for a pregnancy, an endocrinologist will not give you treatment until you have a TSH of 11 or more. Okay.
All right. Excellent. Again, thank you so much for answering that question and for your question indeed as well. Next question is also ready right here. Let me show you. Also having hot flashes and chills with night sweats. What can I do? I'm 44.
I would suggest you to have a consultation with your gynecologist to see your ovarian function. At 45, I don't know how regular are your menses, and but you can be starting a perimenopausal period, which at 44 is an early one, but not an abnormal early one. So I would suggest you to have a consultation with your gynecologist to assess your ovarian function.
Excellent. Thank you so much. And actually, Andrea has added some additional information. So every 28 days, but lasts for 2 days.
All right, that's a normal, but I mean, this is a normal, regular period, but that suggests that the ovaries are ovulating, that you are ovulating every month, but this does not assure us that ovulation is at expense of very high levels of FSH, like your brain is pushing the ovaries to work, and that could be the symptoms that you have of hot flashes and chills and night sweats.
Perfect. Once again, thank you so much for explaining this. And let's have a look at the next question that we have right here. Should we test the progesterone level before and after the embryo transfer? I was given 1,200 of progesterone daily and never had the progesterone tested. I just mentioned that after a few days of taking progesterone, I was not feeling very good.
As I told, in our clinic we have a protocol because of testing the progesterone in the day of the transfer and check the levels. I think more clinic are doing that, or more clinicians are doing that of testing, but it's like a recent adding of the control of the cycle. There are many controversies about that the seric levels can not reflect that the levels of concentration of the vaginal pessaries in the uterus. So I think the dosage is quite high to cover the possible to have a good level of progesterone. I can tell you what we do at our clinic.
Okay, thank you. There is actually a follow-up. Okay, so I will show you. Sorry. Here, it was the case with every embryo transfer. My progesterone tested on 21st day of cycle was always okay, but it was never tested during the preparation for embryo transfer and or afterwards.
And there was a natural cycle or a hormonated cycle with the estrogens and then progesterone.
Yes, if you can just also add this information. Okay, let's wait a second. Egg donation. It was egg donation.
Okay, so I suppose it's what's not in your natural cycle, but in artificial cycle, in hormonated cycle. The only way to know if the level was appropriate or not is to have it tested.
Okay, and also one more thing. Do you test only on the day of the transfer?
We test routinely on the day of the transfer, and if it is okay, we do not test anymore. If it is very low and we supplement with subcutaneous progesterone, in selected cases, sometimes we test again after 2-3 days to make sure that the supplementation is working and we have an adequate levels of progesterone.
Excellent. Thank you so much for your questions and as well as your help with that. And okay, there's one more, so I will go ahead with this. What dose of progesterone do you recommend to start?
Okay, I suppose it's with egg donation. We start with 400 milligrams twice a day.
Okay, perfect. Thank you for clarification. And let's go to the next question. And I just want you to have a look. The patient already would like to thank you for your help.
You're welcome.
All right, perfect. And now let's go to the next question. Is it safer to have twins when doing PGD IVF for recurrent miscarriages comparison to normal IVF?
No, it's safer to have a single embryo transfer. I mean, embryos chromosomically normal, euploid, will have a higher implantation rate. Even if aneuploidy is the most common cause of recurrent miscarriage, we need to minimize the impact of the immunological issues. So the recommendation in recurrent miscarriage is to avoid twins, to have a single embryo transfer. Also because having twins is a risk factor for miscarriage. And a patient with recurrent miscarriage doesn't want to have another miscarriage.
All right. Thank you so much once again for clarifying that.
Well, nobody wants to have a miscarriage.
Of course, definitely. So thank you for your question as well, of course. And right now it looks like this is our last question, but I encourage anyone, if you have any questions, of course, go ahead and type this in. We will be slowly finishing, but of course, I definitely want to make sure that you have asked all of your questions. And the question is right here. So is there any study suggesting miscarriage due to COVID?
Not that I'm aware of. I think the scientific evidence up to today is that there is no more risk of miscarriage with the COVID infection.
Okay.
There of obstetrical complication, and that's why the scientific societies haven't discouraged neither spontaneous pregnancies, neither treatments of IVF or ART.
Okay, excellent. Thank you so much again for that information then. Okay, next question. And also a comment was right. That's great news. Thank you from the patient. And next question is right here. Do you evaluate routine anti-thyroid antibodies for patients with recurrent abortion?
Yes, it's part of the workup diagnostic exams or tests that we do in patients with recurrent abortion.
Excellent. Thank you so much for answering that question. Next question, again, it's right here. What is the benefit of a mock cycle?
Well, there are benefits and there are pros and cons. One of the pros is to be sure that the endometrium will respond properly. Then we can check the progesterone in the mock cycle also and be sure that or know if we need to supplement with the progesterone or not. And we can do also some studies of the endometrium, of the implantation windows, and of the bacterial milieu of the uterus and the amount of lactobacilli. We do not routinely do mock cycle. It depends. We personalize upon the story, the history of the patient. The cons is that you are adding 1 month to the treatment.
All right. Thank you once again for answering this question. Next question is right here as well. If only there are 2 day 3 embryos, is it recommended to do a day 3 transfer with both embryos or with just one embryo, or leave both to try and make it to day 5 before transfer?
Okay, that will depend on the lab of your IVF center. I can speak for our clinic, for IVI, and we are completely sure that our lab is a safe place for the embryo, and we do not perform day 3 embryo transfer. We go to day 5 in all the patients.
All right, perfect. Thank you so much again for clarifying that. I don't see any questions, so just want to give you one last call, like one last chance. So if you have any questions, go ahead and type those in. If not, we will be finishing. But I would already like to thank Dr. Caligara for joining us tonight, for supporting our initiative as well. And you've been excellent with answering all those questions. So happy that you were able to join us. And I'm just still waiting if there is anything that the patients would like to ask. If not, we will be finishing. Okay, someone is typing, so let's make sure whether it's a question or a thank you. It is a thank you, actually. So we will be finishing. So huge thank you, Dr. Caligara, and to all
You're
of you
welcome.
for joining us tonight and for your questions. I hope that it was useful. I believe it was. So huge thanks for that. Dr. Caligara, is there anything you would like to add?
Thank you for inviting me in. Thank you for the questions. And I will say again that definitely to have a baby at home, that is what we all want, patients and doctors. It is better to have one embryo transferred at a time.
All right, understood perfectly, of course. So this is like a take-home message for sure. Huge thanks again for this. And let me just remind everyone that we are having another event at 8 p.m. UK time. So I hope you will be able to join us as well. And this has been, of course, recorded. Therefore, you will be able to find it on our website, myivfanswers.com. And you can find plenty of our previous webinars there. So if you are looking for other questions, just go ahead and visit that website, of course. And you can also subscribe to our YouTube channel, and that way you will be updated with when the new video is uploaded. If you follow us on our Facebook or Instagram, that way you will also know when our new events are coming. As you know, there are plenty more coming. Till the end of June, we will be supporting you. So huge thank you once again, Dr. Caligara. Have a lovely evening. And it's been a real pleasure to have you here with us tonight as well. Thank you so much.
Thank you to you.
Thank
Bye-bye.
you. Bye.